We shall start off with Dr. Elmin Stein. She is the Executive Chair of the Department of Surgical Sciences and the Head of the Division of Surgery at Stellenbosch University. She is Chief Specialist at Tygerberg Hospital, a very busy and big academic hospital in Cape Town, South Africa. Elmin is a registered subspecialist in trauma surgery and also has an interest in transplant surgery, heading the renal transplant program at the Christian Bernard Memorial Hospital. She teaches the STC, Definitive Surgical Trauma Care, and other courses internationally, and is the current president of the IATSIC, the International Association of Trauma Surgery and Intensive Care. May we have your reaction, Elmin?
Hi, good afternoon, everybody, and thank you for the invitation. It's truly an honor to speak after such eminent speakers, and very difficult to top what has been said. And I think I can really, truly, all of us will agree that this has been extremely informative, and the kind of information that even most experienced people still value and enjoy. So I've been thinking that it's such an irony that wisdom is a product not of schooling. We can't learn wisdom, but it is a product of a lifelong attempt to acquire wisdom. And so sharing of wisdom is very, very valuable and much appreciated. Dr. Fald spoke about the balancing act and the three-legged stool. And from personal experience, I can only say that although I absolutely agree that the three-legged stool is academia, clinical work, and research teaching and clinical work, in certain situations, once you become the leader stroke manager, it becomes also a huge burden of administration. And that is sometimes a very difficult task to deal with. And I think that we, in our academic institutions, in many ways have become really big businesses, or shall I say corporate environments, where the expectation is performance, but also financial aspects, and also business principles require a lot of administrative management, and that really impacts on our ability to join our residents and to even play a bigger role in the clinic. And those are the things that we constantly have to monitor. When we speak about the life-work balance, that as leaders in our departments, we have to keep in mind for ourselves. We often joke about, trauma surgeons don't talk about life-work balance. We talk about work-work balance, because we are really balancing the various aspects of our work and the various commitments and requirements that is almost endless. And ultimately, we really have to think not only of ourselves, but also of our residents. I think they are the ones who are mostly affected by this incredible expectation of performance and dedication to their jobs. And yes, we do require that. We require them to be excellent surgeons and to be excellent clinicians and to be at all times performing. But ultimately, they also need to be encouraged and assisted and mentored and supported to learn how to do the balance. And systems don't always allow for that. I think especially in systems where there's an shall I say, underfunded systems or under-resourced systems where human capital is also in short supply, there's a tremendous pressure on the residents to fill the gap, to do absolutely everything in terms of clinical care, data collection, administrative duties, and in our system, our residents are the porters. They're often almost the nurses. They are the ones who deliver the blood samples to the laboratory, who retrieve the results, who have to follow up on everything. So the burden on of non-clinical work in the clinician's life can be very difficult to manage. However, we know that achieving balance is really about, it's our own responsibility. And I agree with Dr. Falz that we can manage some of the modifiable factors. And in essence, as leaders, we need to avoid micromanagement, we need to delegate, we need to be able to create a team of people we can trust. And I often say to myself and others, most of all, we need to triage, and we need to triage our daily activities. We need to triage our goals. We need to triage our tasks that we do. We need to triage almost everything that we have to face, not only our patients. So bottom line is the balance is in our own hands. And above all, I think, apart from responsibilities and the serious nature of the privilege that we have to do the jobs we do, we need to find ways to have fun. Thank you.
Thank you very much for this nice introduction. Before I start with my presentation, I should like to thank the Asian collaboration for trauma care, but especially Professor Rolando de la Cruz for giving me this opportunity to talk today. So my task is to discuss the presentation of Dr. Brazels. It is not so easy to add anything to this excellent presentation. Dr. Brazels first explained the differences between mentorship, leadership, and sponsorship. And she explained how to build a team, and she highlighted that little things might do matter, and the communication should be always in two ways. And the communication should have also a feedback. This should be provided to the mentees. We should always look for building harmony in the team and many other important things she highlighted. I would like to present a few slides to highlight the things what have been mostly said by Dr. Brazels from my point of view. The surgery, the profession of being a surgeon is not only a profession, but it is much more a dedication. And it is expected that the ideal surgeon has a brain of an Apollo and also the heart of a lion and the eye of an eagle, but also the hand of a woman. So to have all these skills by a person who is born as a human and should learn surgery, and here the action of the mentors, teachers, leaders, and sponsors are getting involved. The surgeon should have a minimum of competencies like problem recognition, not only in the trauma bay, but also in the critical care and other parts. The surgeon should be able to perform a trauma laparotomy in a correct way. Also, damage control procedure, damage control idea should be known perfectly. And the surgeon should have also skills in surgical care. But the mentors should also teach them and train them to deal with errors. They should always be planning for errors, although they should always avoid the pitfalls and plan also for the unexpected. Anticipate the errors, develop a fallback position, and avoid the complications. I would like to show you some important mentors and leaders in a historical way. So starting in Austria, 1925, Professor Lorenz Böhler was one of the leaders who established the first orthotrauma hospital in Europe, and this was established in Vienna. He was a surgeon during World War I, so he understood the needs for trauma. He standardized the treatment techniques in orthopedic trauma and recorded and analyzed all the cases. And he started to note the important information on a plaster, on the cast, and so on. The second person I want to highlight is Professor William Gisain from United Kingdom. He, 1941, established the first trauma center in Europe. It was established in Birmingham. And the third one is Professor Harald Czerny. He is born in Graz, in my hometown, and went to Hanover to establish the first trauma center in Germany in the 70s. And it was the very first trauma center in Germany. And he structured the trauma care in the health system of Germany. His fellows, his residents and followers have been the heads of many trauma hospitals and divisions. And so it was possible to have 55 trauma networks and 900 level 1 to 3 trauma centers, accreditation of these trauma centers, and structured education to establish all them in Germany. And if we look to the United States, but in general to Americas, one of the most important mentors and leaders is Professor Donald Tranke. He established the idea of trauma centers in Americas, and he revealed that the patient's outcome in such specialized trauma centers are much better as in non-specialized hospitals. Now, I would like to explain you the different ways of mentorship. There is mentorship. It is probably one of the oldest mentorship, which is oriented to cognitive and behavior-oriented skills. Another one is depending on society's values and norms, like shown here in Sorbonne in the 14th century. But mostly seen a way of mentorship is the school type mentorship. In this case, knowledge and abilities are imparted through planned instruction in the classrooms with frontal teaching. From my point of view, the best way how to develop the intellectual skills of a person is by human relationship, and this might be this might play an important role. So developing a mentorship system can also be taken from other professional groups, like shown here from aviation, the crew resource management, which might also deliver the best care. And from my point of view, we should also take in consideration that the mentors should also teach the safety. And a safe surgeon is one who has the knowledge and who knows what has to be done. But also, this person should have the confidence to know when to stop. I think these are also important facts which should be taken in consideration. Thank you for giving me the opportunity to talk here, and your attention is very much appreciated. Thank you very much.
It's a delegation, and a lot of people, good leaders would delegate surely, but a lot of people do not, and naturally they can't make a good leader. Similarly, I like that mentioning, first think who can do it, not what can be done. I think that was very good, and that is the quality in a leader, to identify who could do what. And sometimes when we are young, we don't realize that why my professor chose him or her instead of me. We cannot figure it out, but later on when we mature, we figure that out also. So Dr. Andrew, at the end, where I was a reactor, I think he took us back in the times when he started with 1966, when the first report came out, accidental death and disability in USA, and that talked about the problem, that it's a public health problem and it needs to be realized that. And then he also mentioned accreditation, and he mentioned Dr. Trunke and his concept of tri-modal death distribution, where in USA that has come down to bimodal because of better care, pre-hospital care, better hospital care. And he also talked about zero preventable death report, something in 2016, which is extremely important concept, basically, if we can do that. And then he also mentioned about the concept of damage control resuscitation, damage control surgery, and the components 1:1:1, which we all follow these days. And again, I think he rightly emphasized the median time to kill, how much it takes, the bleeding takes, and that is still taking its toll, and the adverse effect of excessive crystalloid use when there is bleeding. And he also was a little concerned that mortality has remained unchanged over last 20 years, 2 decades, and that something needs to be done. And he said he believes that speed of definitive care, which we all understand that is something which can bring about outcomes, improved outcomes. And he also mentioned that FFP, particularly in brain injury patients in pre-hospital setting, improved mortality by 30%, which is a very, very significant thing. And then he said what lies in future for trauma, and he said that now we need to move into immunological aspects, biomarker expression in patients with the trauma, like other diseases is happening. So I think the future, he actually is envisioning that will something be more and more. And I think people are working on a lot of immunological aspects in trauma in USA, in India also, our own trauma center. There are a lot of studies are being undertaken on this aspect. And he also emphasized on endothelial damage, precision medicine, and genotypes, and shock resistant, shock sensitive. So somewhere, again, this is the same thing, that what we all are different. We are all individuals, and our biology is different. So that's how we respond to a disease process differently. And trauma is a disease, so that also responds different in different people. The same magnitude of trauma outcome is different in two individuals. That happens. We have seen that happening, and the same thing happens in malignancy. The same thing happens in cardiac disease, coronary disease. So it happens in life. So I think basically we need to keep the life simple, and that is what is work-life balance or the family-work balance. How one can do that, and it is not really difficult. If you ask us now, when I look back, we both of us, my wife and we were working from the beginning. We were both doctors. She is a gynecologist. So if there was a midnight call for her, so I would put both the children in the car on the back seat with a quilt on, and then we will drive, take them there and bring and both of our children, they actually appreciate. They never felt that we didn't look after them as well. And they still say, you are the best parents. So I think we can maintain that work-life balance, the family-work balance. It is not really difficult. Of course, for that, sometimes we have to work a little more. I thank, and it was pleasure listening to you, Dr. Andrew.
Thank you so much, Professor Mistra. I think we already surpassed our time, so I'll not sort of waste time.